Hello everyone. So let's move on to question number 3 for this short answer question paper. So here we have a 55-year-old man presents to the emergency department with a history of feeling generally unwell for 5 days at home. So he reports anorexia, nausea, vomiting, and feeling hot and cold. Um, so he reports 3 days history of right-sided abdominal pain, which has progressively worsened. He records temperature 38.5. So here, very important to mention, the patient has right abdominal pain and it's acute onset. All of these symptoms started in the last few days. So he has acute onset of acute abdominal pain in the right side of the abdomen. And he has a temperature 38.5. His wife noticed a yellow discoloration of his eye, so we have this is could be signs of jaundice. He has noted he hasn't passed any urine in the last 24 hours. This is important sign. It might indicate the patient has element of AKI. His past medical history include type 2 diabetes mellitus, so he is type 2 DM, and hypertension, and obesity, and ischemic heart disease. His medication include amlodipine. Amlodipine, it is the calcium channel blocker. Glucophage, this is oral antihyperglycemic agent. Aspirin, this is non-steroidal anti-inflammatory drugs, and antiplatelet. In this dose, it's antiplatelet. Pramipral, it is ACE inhibitor. This is indirect vasodilators, and it's used for hypertension and for type 2 diabetes mellitus, for renal protection, and used for ischemic heart disease. Ibuprofen, it is non-steroidal anti-inflammatory drugs. So on examination, he is lying in the bed. He is in pain. He has sclera icterus and jaundice. So he had jaundice. So here we have element of jaundice now in this question. This is very important to mention. This patient has right abdominal pain. This is other things to mention. And the patient has temperature. So this triad is called what? This triad is called Charcot triad. Charcot triad, which is right upper quadrant pain. The patient has pain in the right abdominal pain, and temperature, fever, and jaundice. These three triads is called Charcot triad, and these are highly suggestive of acute infective cholangitis or acute cholangitis, which is inflammation of the common bile duct. So let's move on in this question. He has sunken eyes and dry mucous membrane. Why these signs of hypovolemia? Because the patient has nausea and vomiting and anorexia in the last few days, and he's febrile. So all of these can explain why the patient has this sunken eye and dry mucous membrane. Heart rate is 110, so the patient is tachycardic. Blood pressure 85/60, so the patient is hypotensive. This is very important and relevant here. The patient is hypotensive. Temperature 39 now, so the patient has high-grade temperature now. The patient is febrile. Respiratory rate 22, the patient is mildly tachypneic. Oxygen saturation 94 in room air, so the oxygen saturation is fine. The abdomen is tender, so he has tender abdomen in the right upper quadrant and epigastric area. So he has tenderness in the right upper quadrant and in the epigastric area. Bowel sound are audible. Cardiovascular and respiratory exam are normal. So the lab results are as follow. CRB is 250, so he had rise of CRB. This is the interpretation of CRB. This indicates inflammatory process. So patient has ongoing inflammatory process. White cell count is 16. So the patient has leukocytosis, which again, it's indicate there is a inflammation and inflammatory process is going in this patient. Neutrophil count is 12, which is high. Again, this might indicate we have infectious process here. Urea is 20 and creatinine 250. This is called kidney function test, which is urea and creatinine. They are all elevated. So elevated urea and creatinine indicate that the patient has kidney dysfunction. So according to the how high is the creatinine is going up and how low is the GFR is decreasing, we can decide which level of renal dysfunction. Either it's acute kidney injury, or it's acute renal failure, or it's complete loss of kidney function, or sometimes it could be end-stage renal disease. So this patient has element of renal dysfunction. Lactate, it is 2.9, which is high, so the patient has high lactate, which indicate malperfusion, decreased perfusion to the peripheral tissues. Potassium is 4.9. It is normal, but it is in the upper side. So we have to be careful in this finding, 4.9 and with high lactate, because the high lactate will cause acidosis, and this acidosis will exacerbate the increase in the serum potassium. So the potassium is normal. Sodium is 135. It is in the low side. So the patient has hyponatremia, most likely because of hypovolemia, because of ongoing vomiting. Bilirubin is 80 micromole per liter. So here we have a marked increase in bilirubin. So the patient has hyperbilirubinemia. Based on the scenario, in this case scenario, most likely the cause of this hyperbilirubinemia, most likely it's obstructive. Why? Because the patient has right-sided abdominal pain, and he has tenderness in the right upper quadrant. This is one of the things, and and the other things, the other finding here. So the other finding here, we have increase in the ALB, which is alkaline phosphatase, which indicate liver function test. Increase ALB 300, and ALT we have 100. And see this, the ALB and ALT, they are increased. GGT increased 200. So here we have mild increase in ALT, mild increase from 35, the upper limit, to 100. But the ALB and GGT, we have marked increase here, 300 the ALB, and the GGT it's 200. So the increase in the GGT is higher, and ALB is higher than the increase in the ALT. And this is very characteristic for obstructive jaundice. So most likely this patient has element of obstructive jaundice due to acute cholangitis. This is one of the top in the differential diagnosis you have to think about. pH is 7.35. This is normal, but it's in the low side. So the patient, he has element of acidosis, given the rise of lactate. So let's move on to first part of this question. List 4 causes of right upper quadrant pain. Here, this is the list for acute abdominal pain, right upper quadrant pain, right lower quadrant pain. Right upper quadrant pain, it could be hepatobiliary in origin, it could be gastrointestinal in origin, and could be genitourinary causes, could be cardiopulmonary, could be miscellaneous. Hepatobiliary, like biliary colic, like cholecystitis. It could be cholangitis, which is inflammation of the common bile duct. Cholecystitis, inflammation of the gallbladder. Biliary colic, it is a transient occlusion of the cystic duct by small gallbladder stone for few hours. That can lead to transient right upper quadrant pain lasting for less than 6 hours. This is the biliary colic. Cholecystitis is inflammation of the gallbladder, or cholangitis, inflammation of common bile duct obstruction by stone or tumor. Hepatitis, including perihepatitis, portal vein thrombosis, Potkieri syndrome, hepatic abscess or hepatic mass, right subphrenic abscess. All of these are hepatobiliary related. Gastrointestinal, like pancreatitis, presentation of gastric or duodenal or pancreatic pathology or hepatic flexure pathology. Genitourinary, like nephrolithiasis, like pyelonephritis, renal mass or ischemic trauma. Cardiopulmonary, right lower lobe pneumonia, effusion or empyema, congestive heart failure, MI, pancreatitis or pleuritis. Miscellaneous, like herpes zoster, trauma, or costochondritis, infectious costochondritis. All of these are differential of right upper quadrant pain. Let's move on to next part of this question. List 4 investigation other than those detailed above that you would request for this patient. So I would request, I would think about the differential diagnosis. One of the differential diagnoses, it's hepatitis. So one of the most important causes of hepatitis, it's viral hepatitis, either viral hepatitis type A or viral hepatitis B or viral hepatitis C or D or E. So I would like to do viral serology for hepatitis, like hepatitis B surface antigen, HBs antigen, or hepatitis A virus IgG and IgM, or hepatitis C virus IgG and IgM. All of these, it can be done to rule out the infectious causes of hepatitis. So a pancreatic function test I would like to do. Why? Because it's amylase, serum amylase and serum lipase for gallstone pancreatitis. To rule out the cause of this pain, it's pancreatitis. So I would like to do this. Coagulation profile is very important. Coagulation profile, it is important to prepare this patient, because this patient, he has acute abdomen. So this patient might need surgical intervention at any point. So you have to prepare this patient for operative intervention or surgical intervention. Coagulation profile is one of the investigation has to be done. You have to be careful, because you have to mention other than those detailed above. So coagulation profile is not mentioned in the question. The full blood count and liver function test and kidney function test already mentioned, so you can't answer them in this part. Urine analysis here is very important. Why urine analysis? Because one of the differential, it is urolithiasis, and one of the differential is pyelonephritis. So here we have nephrolithiasis and pyelonephritis. So these things we will detect abnormal finding in the urine analysis if we have urolithiasis or pyelonephritis. And the other things we can request what is called urinary orobilinogen and urinary bilirubin. It can help to differentiate between the different types of jaundice. We have three types of jaundice. We have prehepatic, we have hepatic jaundice, and posthepatic jaundice. And the urinary orobilinogen and urinary bilirubin and stool stercobilinogen, which I mentioned them here, stool stercobilinogen and urinary orobilinogen and urinary bilirubin, can differentiate between them. And as well, we have to order direct and indirect bilirubin, because in cases of prehepatic jaundice, the indirect bilirubin will be elevated. In cases of hepatic or posthepatic, most likely its direct bilirubin will be elevated. In this patient, for example, in the top of the differential diagnosis, it's going to be cholangitis. And in the cholangitis, you will find direct bilirubin will be elevated. Chest X-ray is very important here to rule out cardiopulmonary causes for this right upper quadrant pain. Ultrasound here very important for gallbladder stone, for acute cholecystitis. Ultrasound is very sensitive and highly specific for this pathology. ERCP ultrasound, or there is other test is called HIDA scan, but HIDA scan is rarely done nowadays. HIDA scan is more sensitive, and I think it's more specific even for acute cholecystitis, but ultrasound is less invasive and it's more common use nowadays. ERCP or MRCP, ERCP stands for endoscopic retrograde cholangiopancreatography, MRCP magnetic resonance cholangiopancreatography. It can be used definitely for suspected common bile duct stones. The ERCP, it's diagnostic and therapeutic. MRCP is only diagnostic, and they have high sensitivity and specificity for diagnosis of common bile duct stone, and sometimes for common bile duct, which is called cholelithiasis. Abdominal CT scan also, it's helpful here, I think, to think about intra-abdominal pathology like liver abscess or thrombosis, for example, like Budd-Chiari syndrome or hepatic abscess or hepatic mass. It can be the abdomen CT scan. I think it will be useful. So acute abdomen here, briefly, in all patients presenting with an acute abdomen, order the following key tests for specific diagnosis: ALB, ALT, AST, bilirubin. All of these already ordered in the stem of the question. Lipase and amylase, it is not mentioned in the stem of the question, so you have to mention them. Urine analysis is not mentioned, you have to mention them. Beta SCG, if the patient is woman in the childbearing age. Our patient, I think he is a male patient, So it is, so he is a male patient. So it's no idea to put the beta ECG here. If she is female in childbearing age, you have to put beta ECG. Troponin here, you have to mention, I think, troponin for cardiac causes. And lactate already mentioned in the stem of the question. This it's already mentioned. And a key test for operative room preparation, CBC, electrolyte, creatinine, glucose, INR, PTT, which is coagulation with chest X-ray, ECG. Note, choosing wisely does not recommend routine preoperative blood work for ambulatory or elective surgery. Here we are not talking about ambulatory and elective, we are talking about emergency surgery. So let's move on to the third part of this question. From the clinical, so here, vignette. So from the clinical vignette provided above, list two initial management steps you would like to initiate in the emergency department. So here we have a patient presented with acute abdomen. So here we have acute abdomen, and the patient query, he has a acute cholangitis, all of these based on the clinical data in the stem of the question. So the patient is a query acute cholangitis and he has acute abdomen, and the patient is query he had a sepsis. And the source why I'm talking about sepsis, because the patient is hypotensive. This patient is hypotensive, and so the patient might have either sepsis or hypovolemia. So the patient has query sepsis and complicated by septic shock, as well. The patient has hypovolemia. All of these diagnoses or provisional diagnosis, the patient can explain the clinical situation and the clinical state of the patient. So the patient has hypovolemia, and this hypovolemia can lead to shock, definitely. And the patient has sepsis, and the source of sepsis, it's query biliary source, because the patient has jaundice. So the other things in the provisional diagnosis, the patient has element of AKI, acute kidney injury. So all of these, our provisional diagnosis for this patient. So we would like to do? Well, usually in the management here, so I would like to start with ABCD approach. Airway, make sure the airway is secured, and B, breathing, make sure the patient is oxygen saturation is above 94%. And the patient has oxygen saturation, I think, above 94%. His circulation here is very important. The patient is hypotensive. So I would like to put two big venous cannula in the upper limbs, in the antecubital fossa, and I would like to start to take blood sample while I'm putting these lines, and send for basic blood tests, for routine blood tests. And I would like to do an EBGs to check the acid base and the gas exchange status of the patient and electrolyte status. And then I would like to start resuscitation fluid, isotonic fluid like Hartmann solution or normal saline, for example, 1 liter of normal saline over as a resuscitation over 30 minutes. So D, I'd like to check the level of consciousness, the AVBU score of the patient or GCS score of the patient, and E, its environment. This patient, I have to treat this patient temperature because the patient is febrile, and I would like to consider admission of this patient to either high dependence care unit or to ICU. So admission to HTU or ICU in terms of environment. So this is the approach. I think it is a correct approach. Screening for sepsis here, very important. We have a sepsis form. So if the patient has SEERS, which is 2 out of 7 from the SEERS criteria, plus infection, when the patient has element of infection here, so the patient will have sepsis. So if the patient is screened positive for sepsis, I have to start sepsis 6 within first hour of suspected sepsis, which is I'd like to take 3 things, which is the measurement of urine output and serum lactate level monitoring and follow up, and I would like to send for relevant cultures here. You can send for blood cultures. And 3 things to give: it's oxygen if the oxygen saturation is than 94%, and IV fluid resuscitation and challenge of IV fluid, and broad spectrum antibiotic according to the local hospital guideline. Admit to HDU and ICU. This patient, he is in need, and he most likely he is scoring in the IMU's Irish early warning score more than required criteria for admission to HDU and ICU or for escalation of care. So this patient will need for admission to HDU and ICU. Hydration with IV fluid here, very important, and this is very one of the point in the sepsis management. MPO and NG tube if persistent vomiting from associated ileus. Analgesic, simple paracetamol. Opioid like morphine, we can avoid non-steroidal anti-inflammatory drugs because of the patient has element of acute kidney injury, so we have to avoid NSAIDs. Antibiotic according to the local hospital guideline, according to the local hospital antimicrobial guideline. Here we have the sepsis form. It's the HSE form for inpatient, for emergency department patient. So likely infection, screening for sepsis. If the patient in INUs more than or equal 4 or more than or equal 5 on oxygen, or INUs less than 4 or less than 5 if the patient on oxygen, in immunocompromised patient or elderly person, and ED sepsis screen at triage. So here the likely infection screen for sepsis for this patient. So check for 1, 2, 3, risk for neutropenia if the patient on chemotherapy or on radiotherapy. This is the first one. Then 2, clinical evidence of new onset of organ dysfunction, and I will show you what's the new onset of organ dysfunction. This is the new onset of organ, clinical evidence of new onset of organ dysfunction, and this is risk of neutropenia, patient chemotherapy or radiotherapy. And the third one, it's a systematic inflammatory response more than or equal to CS criteria plus 1, more than or equal 1 comorbidities. So this is the approach. If the patient has, if there is evidence of 1, 2, or 3, 1, 2, or 3, so 1, 2, or 3, so 1, 2, or 3. So either it is so 1 and 2 or 3, so either 1 and 2 or 1 and 3. This patient is highly likely have sepsis. Continue sepsis form and place. So start the management for the patient as he has sepsis. So if there is no evidence of either 1, 2, or 3, there is no evidence. So this is follow the usual management pathway. So here we have if the patient again he has at risk of neutropenia, the first point, and second point, the new onset of organ dysfunction, and if the patient is scoring more than or equal 2 points from the SEERS plus 1 comorbidities, this patient will be treated as a sepsis. And we have to think immediately what is the source of sepsis, and we have to start treatment, which is sepsis 6 bundle. Sepsis 6 bundle, we have to start sepsis 6 bundle within first hour of suspected sepsis. We have to take 3 things, which is blood culture and blood test and urine output assessment, and 3 things to give IV antibiotic and IV fluid and oxygen therapy. This is very important to mention. This is risk of neutropenia, which is the patient on chemotherapy or radiotherapy who need to get the sepsis 6 treatment bundle. infection plus any one of the following. So infectious site could be respiratory tract, could be skin, could be central nervous system, could be intra-abdominal, could be catheter or device related, could be urinary tract, intra-articular or bone, or could be sometimes unknown. So infection plus any one of the following, either 1 or 2 clinical evidence of new onset of organ dysfunction, or 3, which is systematic inflammatory response syndrome plus 1 comorbidities. And 3 things you have to take and 3 things you have to give, and it's all mentioned. So this is the evidence of infection and new onset of organ dysfunction. Lactate more than 4 millimole per liter after 30 minutes of intravenous fluid therapy. Cardiovascular systolic blood pressure less than 90, mean arterial pressure less than 65, systolic blood pressure more than 40, below patient normal value. Respiratory, new need for oxygen to achieve saturation more than 90%. Renal is creatinine more than 170, and our patient has creatinine 250. Urine output less than 0.5 ml per kg for 2 hours, despite IV fluid. Liver bilirubin more than 32 micromole per liter. Hematological platelets less than 100. Central nervous system, acute altered mental state. These are evidence of infection and new onset of organ dysfunction. So here, let's move on, continue to the same question. The patient has urinary catheter inserted and has no urine output. Renal function is repeated as the following result. Creatinine now 400, so he has a massive rise in creatinine. Urea is 24, also he has a rise in urea. So, but the rise of creatinine more than urea. Potassium 5.5, the patient has hyperkalemia now. pH 7.34, the patient still, patient pH is normal, so the patient is most likely is compensated still. And bicarbonate 20 is low, so bicarbonate is low, so the patient has element of metabolic acidosis, but he's still compensated because the pH is still normal. List the 2 medication that you would like to discontinue in this patient, giving justification for each one. Here, very important, you have to mention the 2 medication and you have to mention your justification or your explanation why. Here, the medication, the patient in the stem of the question, amlodipine, you can continue with, or amlodipine, he is antihypertensive. So the patient is hypotensive. In the stem of the question, is the patient is hypotensive. The patient is high, as I mentioned before, the patient blood pressure is 85/60. So amlodipine, you can't continue with amlodipine. Amlodipine is antihypertensive medication, so you have to stop this. This is calcium channel blocker, indirect vasodilator, so it can cause a drop of blood pressure, so you have to stop this. Glycophage, you have to stop glycophage. Why? Because the patient has lactic acidosis. Lactate is high, and the lactic acidosis can get worse with continuous of glucophage in patient with renal dysfunction or liver dysfunction. This patient has element of renal dysfunction and renal failure, and the patient already has also as well liver dysfunction. This patient with liver and renal dysfunction, glucophage can cause what is called lactic acidosis. So glucophage has to be stopped, and this is the justification. Aspirin, here, this is non-steroidal anti-inflammatory drugs. I think it has to be stopped because and ibuprofen is the same. They are non-steroidal anti-inflammatory drugs. Why they has to be stopped? Because of they are affecting the afferent arteriole of the kidney. They inhibit the prostaglandin. Inhibiting of prostaglandin will cause afferent arteriole vasoconstriction, and this will lead to risk of kidney damage or pre-renal azotemia or pre-renal acute kidney injury. The patient already he had renal failure, so by continuing this medication, the patient will get more and more kidney damage. Ramipril has to be stopped as well. Why? Because ramipril, it can cause hyperkalemia, and the patient already he has hyperkalemia, so you can't continue with ramipril as well. And the other things, ramipril, it is indirect vasodilator, can cause drop of blood pressure, so you can't continue with ramipril because the patient is hypotensive already. So all of this medication has to be reviewed and has to be stopped. So this is very important. This is the NSAIDs and ACE inhibitor. The NSAIDs, they are affecting the afferent arteriole. They cause constriction of the afferent arteriole and potential for kidney damage. The ACE inhibitor it is dilate the efferent arteriole. It can cause kidney protection in healthy in underlying normal kidney. If the patient has already acute kidney injury or the patient has acute renal failure, ACE inhibitor and ARB should be avoided. This is the justification. Metformin, glucophage, metformin associated lactic acidosis can occur acutely in an overdose, but typically has more gradual onset in patients with hepatic or renal dysfunction due to decreased excretion. And our patient has already renal and hepatic dysfunction. Let's move on to next question. Following the management of the renal failure, the patient transaminase level are persistently dearranged. An ultrasound scan of the liver and gallbladder show dilated common bile duct measuring 15 millimeter, which is dilated common bile duct, and multiple stone identified in the gallbladder. List 2 investigations that you would like in diagnosis and or treatment of this condition. I think we have MRCP here, magnetic resonance cholangioscolpography, 90% sensitivity for ambulatory region and biliary and pancreatic anatomy. It is non-invasive diagnostic test of choice. We have ERCP. ERCP, it is for CBD stone in periambulatory region, diagnostic and therapeutic at the same time. We have these, I think the 2 is the most common and most available. We have old technique, I think it's not used nowadays. It's percutaneous transhepatic cholangiography, percutaneous approach to proximal biliary tree via the hepatic parenchyma. Sometimes useful for proximal bile duct obstruction when the ERCP fail or not available. This is the list 2 investigation that would helpful in diagnosis and or treatment. The patient undergo surgical procedure. You go to review him in the ward 48 hours later, so 2 days later, and he feels unwell and he has temperature now 38.7. Name 4 common causes of postoperative fever, 6 W's of postoperative fever. When postoperative day number 1 to 2, it's pulmonary, it's atelectasis or pneumonia. Usually in day number 1, it's atelectasis. If it's in day number 2, it's pneumonia. Water, postoperative day number 3 or to 5, it's urine, it's UTI. Wound, it's postoperative day number 5 to 8. Wound infection, if earlier, think about streptococci or Clostridial infection. Walk, it's postoperative day number 8, thrombosis, DVT or BE. Wonder if drugs is the cause, postoperative day number 1, or drugs can cause this, but antibiotic and sulfa drugs are the common causes. We did we cause the fever, postoperative day number 1, it's central line infection or transfusion reaction. So here, postoperative fever, hours after surgery, postoperative number 1, it's inflammatory reaction in response to physiological stress of the surgery. It's unlikely to be infection unless it is necrotizing fasciitis or another severe infection. Reaction to blood product received during the surgery or malignant hyperthermia. Postoperative day number 1 to 2, it could be atelectasis, most common cause in day number 1, and early wound infection, especially if the cause was Clostridium or group A Streptococcus. Aspiration pneumonia, usually in the day number 2. Postoperative day number 3 to up to day number 7, likely it's infection the cause. UTI, one of the causes usually in the day number 3. IV site or line infection could be IV site or line infection commonly with Staphylococcus. Septic thrombophlebitis, leakage at the bowel anastomosis between day 3 and day 7. It can cause tachycardia, hypotension, oliguria, and abdominal pain. Postoperative day number 8, it's intra-abdominal abscess or DVT or BE. And we have other causes sometimes, like upper respiratory tract infection, could be infected seroma or infected biloma or hematoma. Biloma, it is accumulation of the bile within abdominal cavity. It can be one of the complications for this patient because this patient has intervention in the biliary tract. This is the final part of this short answer question. I hope this discussion is helpful and it's useful for your preparation, for your exams. Again, I'd like to remind that I did already course in the teachable.com website, and I will include all of the previous videos for the discussion of short answer question, and I will upload all of the future discussion for short answer question and for MCQs, for the past paper MCQs, and I will do a quick and crush review course for the most important and relevant topics in the module of trauma preoperative and critical care and emergency medicine module. I will put the link for this for the teachable.com course in the description for this YouTube video, and I am more than happy to hear from you for your feedback. And if you have any question, I will do my best to answer and to help you in your preparation. Thank you for watching my video, and hope you the best in your preparation for your exam. Thank you.